Oh, okay.
First schedule says that room, and then electronic says this
Well,
room.
we're all here now. Okay. Good morning, everyone. Thank you for coming. I know it's Friday morning at the end of the conference, and it's like 99 degrees out today, but thanks for being here. My name is Sam Sondheim. I'm the Assistant Medical Director at Mount Sinai Morningside and faculty there, and core faculty at our Center for Healthcare Readiness at Mount Sinai. I'm the SAEM Disaster Medicine Interest Group Chair, and we're thrilled to be supporting this didactic session with two leading experts. I'm standing among giants here, and I'm honored to be here. So I wanted to give a brief introduction. Before we get started, we're going to talk a little bit about healthcare practices for mass shootings and for MCIs, and how to handle MCIs in this current state of crazy boarding and being able to adapt to a no-notice event. So some conflicts of interest are up here for Dr. Goolsby, a patent pending, and a consultant for Zoll. Thank you to Matt Levy for helping with some of the slide preparation, and Dr. Bittinger's funding from ASPR and the CDC. A little bit about our speakers today. Dr. Goolsby is the Chair of Emergency Medicine for Harbor UCLA in LA. He's a professor of clinical emergency medicine at David Geffen and holds multiple national and international roles at scientific organizations, including the American Red Cross and International Liaison Committee for Resuscitation's First Aid Task Force. He is a graduate of the U.S. Air Force and served active duty in the U.S. Air Force, including 2 tours in Iraq, and has become a leading expert on military to civilian knowledge transfer, including a multi-million-dollar research portfolio focused on bleeding control, tourniquet usage, emergency response, and MCI care. He has over 70 publications, and we're thrilled to have him here today. Dr. Bittinger hails from the Northeast. He is the Chief Preparedness Officer at Mass General Brigham and the Endowed Chair of Emergency Preparedness. He directs the Center for Disaster Medicine and holds appointments at both Harvard and Chan Medical Schools. He's a medical officer for MA1 DMAT team and the RDHRS Region 1 Medical Director. He's an expert in disaster preparedness, response, and has countless authored papers and chapters, and has been an unofficial mentor for me for the past few years. So I'm thrilled to have you both here. A little about the objective. Today we're going to talk about healthcare responses and the lessons learned from recent U.S. mass shootings. As probably most of the people in this room know and you're interested in this, there's no doubt that man-made disasters and natural disasters have both been on the rise over the past 2 decades in our country. We're going to describe some best practices in emergency medicine, pre-hospital care, and surgical responses for mass shootings, and how current ED and hospital crowding challenges the MCI space and readiness in terms of the landscape and real estate to be able to respond to a large volume of a surge of patients coming in when we're already pretty cramped. And we'll talk about strategies that can effectively mobilize our resuscitation capacity in the setting of these overcrowded EDs with the current boarding. We'll talk about why this matters, mass shooting incidents, some background and the scope of the problem, a couple studies and key recommendations, and how we make it happen with crowding and boarding and balance that all despite the challenges that we're currently faced with across the country. And with that, I'll turn it over.
All right, thank you, Sam. It's great to be with everyone this morning. Apologize for starting a couple minutes late. I've never had this happen before where we get double booked into the room next door, but so the printed schedule said something different than the online, and glad you were in here getting us started. So now we're back on track. Okay, so I wanted to spend a couple minutes talking about why this matters, some framing. And so we're going to go through a little bit of information about what the definitions are and sort of the scale of it. But people think about a lot of things when we talk about mass shooting. It conjures up ideas of terrorism, lots of different sort of mental images. And you know, some of these are pretty dramatic when we think about things like the Las Vegas shooting, and you have a headline that describes trunks full of injured people. This is really quite a terrifying situation. And so to just put some framing around what it is that we mean, a mass shooting is a type of a mass casualty. And so fortunately we're going to get to talk a bit about both of these things today. And I think probably a lot of people are familiar with the definition of mass casualty, which varies based on the place you're in, but is basically an event that's so large that it overwhelms your local resources. So that might be several patients at one site, it might be 10 patients at another site, but whatever that is, that varies a little bit depending on your local setup and your resources. For a mass casualty, there's lots of different types of causes and injuries. These can be intentional or unintentional events. So it could be an earthquake, it could be a shooting, and varying types of injuries that could take place from like blunt and penetrating. And then a medical response is usually a prominent factor in responding to a mass casualty. A mass shooting being a special type of a mass casualty is a little bit different. So one of the key things is it's a very fast-moving mass casualty incident. So if you think about an earthquake, for example, the event happens, the earthquake's very fast, but the injuries and the response may be a long time coming after that, right? A building collapses and somebody's trapped in rubble and the injury's ongoing for hours and hours and hours as the rescue takes place. And a mass shooting may literally occur in like seconds. So it may be done in less than a minute, rarely longer than several minutes at a time. And so the event is over, and then the injuries are happening, and then medical care is responding to all of those at once. These are penetrating injuries, so we're really focused on a particular type of trauma that's taking place. And they have a lot of potential for psychological harm, et cetera, even more so than some of the other dramatic mass casualties we might see. A big law enforcement presence, and one thing that's really interesting as we got kind of into this mass shooting space is there's not really a unifying definition for it. So people have lots of different things that they talk about, but I think probably one of the more common ones we see is 4 or more people that are injured in a single incident. And there are a lot of differences that we're not going to get into today from routine gun violence in terms of like the types of people that are doing the shooting. I hate to have to use the term routine gun violence, but we do have to separate that from what we're talking about here with a mass shooting. So for example, things like mental illness are not necessarily linked to routine gun violence, but they are linked more to mass shooting. There's different types of weapon lethality. So, instead of a handgun, people are often using long guns, rifles that are more dangerous. And this talk today is not going to focus at all on prevention. So I think that that's not the most important thing that we could potentially be talking about, but these events happen. And so what we're focused on today is what happens. When the event happens, what do we do afterwards? How do we make healthcare response better? Okay, so what's sort of the scope of the problem? So this is from the Gun Violence Archives. It seems like it's getting worse. So when we looked at the 2019 data, there were 400 mass shootings in the United States. That's 655 for 2023. More people are dying, more people being injured as well. I think there was a little hope from 2019 to 2021. We saw this big spike that maybe that was pandemic-related, civil unrest that was taking place, but unfortunately the 2023 data looks pretty similar to 2021, has not reverted back down to 2019. So the total number of people involved, if you look at the killed and injured, is not a huge number, right? This is not like a cardiac arrest where there's just like tons and tons of people that are being involved in it. But it's not a totally insignificant number of people either. And certainly from a psychological standpoint and a preparedness standpoint, it's pretty alarming that statistically more than one mass shooting takes place in the US every day. And so even though the likelihood of your community or your hospital being the one affected is low, that's a kind of dramatic thing to think about, that every day in the US there's a mass shooting that's going to take place, and are you ready to take care of it? And then when it's one of the really big ones, then are you going to be ready for that? Unfortunately, there's a very high fatality too. About half the people involved in the Orlando Pulse shooting were killed. And so when you think about, traumatic injury, traumatic event, having these kind of rates of people killed is significant. So knowing this is a big problem that seems like it's increasing and it's a bit of a unique type of a mass casualty, we decided to do a study. The QR link was on one of the earlier slides, and we can go back to it later if people need to scan that, for the study to look at what are the best healthcare responses that we could do, that we could think of in responding. And as you can imagine, this is a tough area to study, a little difficult to draw data from. But what we did is we decided to pick a unique group of participants for our study in a consensus building method. And for the participants, we took EMS clinicians, emergency physicians, and surgeons who were actually responders and participants in 6 of the largest recent US mass shootings. So we had people from all of these sites, Las Vegas, Orlando, Dayton, et cetera, that participated in the conference. And we did a series of things with them. We sent out some surveys to start with, focusing on the 4 S's. So talking about the staff, stuff, systems, and space that was relevant to their response to their mass shootings. And, ask questions like, what did you run out of? And was there enough space to treat your patients? And, got some responses to start shaping things. We had all of the participants present on the first day of the conference by site. So all the Las Vegas people presented together, the Orlando people presented together, and then our study team did some coding, et cetera, looking at the types of information they talked about. And then the next day, as we ranked the priority themes or the priority lessons learned, we did that by specialty. So we had the EMS clinicians together, the emergency physicians together, and the surgeons together. And what that yielded, excuse me, is 8 key recommendations. And so for my part of the talk, if there's sort of a most important slide, this would be the most important slide. And I'm not going to read it because I'm going to go into each of these in a little more detail. But these are what we came out as the key recommendations from the study. And this is all 3 of the subgroups had to have this theme as a priority for it to make that cut. So the EMS folks thought it was important. Our emergency physician colleagues thought this was important, and the surgeons did as well. And so let's go through each of these in a little more detail to talk about kind of what they mean and the context of it. And I would say at the outset, what I really loved about the themes and the lessons learned and the recommendations that came out of this study is that it really spans the gamut of things that are quite achievable, like you could kind of go home today and maybe you're already doing some of these things and it would take a bit of a tweak, or you could implement something fairly easily, to stuff that would be really, really tough to implement, but is nice kind of like pie in the sky or strategic thinking about how we could make things better. And so as we go through these, we're going to talk about a bunch of those. So this one is on the more achievable end of the spectrum. Does everybody have sort of a Stop the Bleed program in their locality? The hospital's doing something, et cetera. So probably most of you already engaged in this. For me, having worked in Stop the Bleed for many, many years, it's exciting to see that this was a recommendation that came out. And anecdotally, our participants noted many tourniquets that were applied in these mass shootings and felt like they were helpful for these extremity injuries that came out of it, often applied by like police officers, so non-medical professionals applying these devices. And so thinking about how do we make the community ready, which I really found to be interesting because this was a consensus conference on healthcare response. And our healthcare professionals recognize that it's very important that those immediate responders, that the community in an event like this in particular is ready to respond. And so Stop the Bleed, run, hide, fight training, these things that are going to sort of make people safer and then ready to respond, they felt like were important and an essential part of a healthcare response to a mass shooting. Okay, so this next recommendation I really like, and this gets into the realm of much more difficult to achieve, but I think really interesting to think about. So our participants noted a lot of challenges in getting people to the right place at the right time. And so that's a challenge in all of healthcare, right? We want to get the right patient, right place, right time, right procedure, right medication, all those kind of things. But in the chaos of a mass shooting where you're dealing with maybe hundreds of people all at once, how do you get them to the right place when they're all going at the same time? So this is different than the earthquake, right? We're not pulling somebody out 5 hours after the building collapses, and then we got one patient that we're transporting and we can get them to the right place. This is hundreds of people going, and they're taking themselves. They're jumping in the back of pickup trucks. The friends are loading them over. They're walking. And so how do we do this? And I think if you went to most people in your community and said, hey, where's your level 1 and level 2 trauma center in the area? Like, my guess is you're going to get some blank stares on that. So what can we do? I don't have the answer to this, but our participants had a lot of discussion on things like, should there be training for the communities to communicate those kind of things? These are the capabilities of your local hospitals. But maybe even better, what if, and this is why we have the Google Maps symbol up here, what if when the shooting happens and all of a sudden the people in an area are all Googling hospital, and you're able to link that somehow and say like, oh, okay, these are the types of hospitals that would be best for you to get to if you could do it, rather than necessarily just the closest one. I don't know how all that would work, how that might link in with dispatch, various different types of considerations, but certainly in Las Vegas, they saw a lot of people that went to non-trauma centers, which was challenging. And actually the trauma centers were busy, but they weren't as busy as they expected, at least initially, compared to some of the closer hospitals to the shooting site. We talked a fair amount about triage, and I'm going to come back to even some of the information on this slide throughout the conference. And one of the key recommendations was for this concept of iterative triage. And we may do this to some varying degree already. You have a sick patient, you come back to check on them, and that's sort of a form of triage or follow-up. But most places, a patient checks in, they get screened by the nurse, the provider in triage, and then the triage process is sort of over. But here at a shooting, especially with the chaos that may surround it, you can imagine that it's important to have an on-scene triage by the medics to try to determine who's going to go first and go where, and an ED triage to decide who gets prioritized in the department, and then an operative triage. So if you've got 6 patients that have to go to the OR now, who really has to go first? You only have 3 ORs available. What type of surgeons are available to take care of them, et cetera. And so thinking about this process of triaging and re-triaging and then triaging again came out as really important. I'll say anecdotally in my experience serving in Iraq on a couple of tours, this is something we did and found it very valuable as well. And it's sort of taking that chaos of these mass injuries and then how do we look at it over and over again to make sure we're not missing folks. Okay, this one I think is interesting in that it's kind of seems obvious, like we should have good communication, and then yet also like what this recommendation specifically is saying is that it has to be between the scene and the hospital. And I'm not sure that everybody has this. Like, do you think in your ED you have a capability to reach the medic who's on scene with the patients? Do folks have that? Anyone? No one has that. Okay. On scene poor? Yeah. Yeah, and I think that the systems we dealt with also did not really have that capability, and they almost all found workarounds for it. So it was a matter of the physician on duty, like calling the fire chief buddy who was on the scene, that was taking place and sort of getting some direct information. And a lot of places are going to have various ways this is routed, through a base hospital or a medical alert center. If you're in LA County, various places where these are going to be kind of routed around. But the participants really felt like having that direct understanding of what was taking place on the scene without all the intermediaries in real time was helpful in the preparation, making sure that the response was going to be adequate as well. So thinking about this, like maybe there needs to be some ways where this can be more expedited, or even just simple things again, like making sure you know how to contact the fire chief, the incident commanders that may be out there to help provide some real-time medical information. Okay, this next one is difficult, but I think remarkably important, and I did another consensus study looking at the COVID response to healthcare in New York. Michael Redlener was working on that as well. And this basically, so very different problem, right? A viral illness, pandemic. I was looking at the military response in one city. The same recommendation came out of that group as well. So this is something that I think applies to a lot of different things, the idea of how do we universally track patients. And so what our participants in this study found was challenging to know how the person who's shot on scene, and they go to the first hospital, which was maybe the wrong hospital, or they were sicker than anticipated, had to be re-triaged to the trauma center, and they eventually go to rehab. Sometimes they just get kind of lost in the shuffle, hard to be able to link them up with family members, et cetera. And then it's really challenging to understand outcomes and what interventions made a difference. So from sort of kind of a research and understanding our trauma care, this becomes really important, but also just from patient tracking in the midst of lots and lots of patients when there's confusion about what's happening. So could we develop a universal barcode of some type that's going to talk to Epic and Cerner and the EMS systems and the rehab systems? Not yet, but it would be cool. It would certainly be cool if that could happen. And in this type of a circumstance, was thought to be quite important. Alternative care documentation. I imagine most people have downtime procedures, paper charting, and things that will take place for when the system goes down. And in this case, the system is not down, but the system is just overwhelmed. So if you have a couple of patients that arrive at a time, your registration people or whoever's entering the information can probably do that quickly, get people into the computer. But if 50 people that arrive at a time, then what are you going to do? And so being able to have a paper process or some alternate process where at least charting orders and things can get started until all of that registration process can catch up. I found this recommendation somewhat unexpected, I guess, and I thought really interesting and important that family reunification was one of the things in our healthcare response that was deemed to be so important. And the specific challenge here was the overwhelming volume of people that you're dealing with. And so a couple of things that were noted is that the families tended to go to one of two places. One is they go to the site where the shooting took place, which is problematic, as you can imagine, right? You're trying to evacuate people out, and there's police presence and the chaos and things that are happening there. Or they go to the hospital. And so when we have a distraught family come in, we're really good at dealing with that distraught family. We've got a family room, we have social workers, child life, all the stuff to take care of them, but we don't have those resources to take care of 50 distraught families. And that can really kind of gum up the works in terms of taking nurses or physicians or other people to deal with that, taking up space in the hospital that may be needed. And so what is the plan for where can those folks go? How can they have meaningful, as real-time communication as possible to find out what's going on with their loved ones? And so making sure that there's a a community plan to take care of this, which will vary a bit by location, but having that in place is essential. And then this is our final of the key recommendations, so the 8th of the recommendations that all 3 of our subgroups agreed on, which is a tailored mental health after action response. And, you know, as emergency physicians, I don't know what it's called that we have, but I kind of think we all probably have something on the spectrum of PTSD, right? Because we see like this really bad stuff every day. We see people in pain, we see horrible things that happen to people dying, abuse, just all kinds of bad things in our normal lives. And despite that, our participants who went through these mass shootings all said this was so much worse. Like the overwhelming volume of it, the horror of it was so bad that they really felt like having this mental health response ready was essential. And it needs to be tailored, and that not everybody's going to want the same thing. So I may want to do a group counseling, someone else may want something individual, someone want to use online resources, someone doesn't want to use anything. And then also dealing it with the things that they're going to see. So the EMS people on scene, what they see and deal with is different than what we're going to deal with in the department or what the surgeons are going to deal with in the operating room. And so having that sort of thought about, at least some planning around that and some resources available, I think this is highly achievable. When we had our teams deploy to Turkey in response to the earthquake there, we had a number of options like set up for people when they were returning home, again, trying to tailor to the experience that they were going to see and that our hospital could provide for resources for them. So I think we can have this ready. We've got the capability to have mental health response in our facilities, and so it's just a matter of having a little bit of forethought and organization to do that. Okay, so those are the 8. There's several more here. I'm going to go through these much more quickly. These are recommendations that 2 of our subgroups recommended. So the red dots are EM and surgery had the same recommendation. Purple dots are EMS and emergency medicine had the recommendation. And then there's some black dots on the later slides that were surgery and EMS. So I'm not going to read all of these, but I'm going to highlight a few as we go through. So the first dot talks about trauma preparation for people that don't routinely take care of trauma patients. And so, you know, things like ATLS or your trauma nurse courses, for example. So while I don't necessarily think we as emergency physicians need to take ATLS, it was noted for sure that there's, you know, hospitalists involved in this response, floor nurses, people that may not really be normally taking care of trauma patients, particularly in the more acute phases of a response like this. And so having some additional capability in your system of people that are familiar with this was quite valuable for the participants in their response to this. This third dot on here is going to talk about triage again. And one sort of repeated theme that came up was that everybody had triage plans in place at their hospital. So they had SALT or START or some modified version of those kind of standard triage protocols. And basically everybody either on the fly abandoned or modified those while these events were taking place, which is a little alarming or concerning, right? Because you drill on these things, you have a plan, you're going to use them. And so in the real time, why are people changing this approach? And what happened in practice is that most of those triage protocols that are out there don't really consider the injury itself, right? They're looking at sort of like, you know, can people talk? What are a quick vital sign assessment? You know, sort of things like that, but not really what actually is the injury, what's going on with the patient. And it's, you know, if you think about what we do on a daily basis, if we get a call from the medics that they're coming in with a patient with a bullet in the chest, we're pretty concerned about that, right? That's like gonna get that's like the top thing, right? That's what we're there for. We're there for that top thing. We're gonna do the big bells and whistles. It's the full trauma activation, you know, the tier 1, the TTA 1, whatever your terminology is. And then at the same time, you could have that patient who comes in after a mass shooting with a bullet in the chest, and depending on what their screening was like for one of our triage protocols, they may not be the top thing. So what happened in practice was most people kind of abandoned that and said like, well, a bullet in the chest, even if they don't quite meet it, we're going to still put them as kind of an immediate casualty. And so it made us wonder, and made our participants wonder, that maybe we should think about sort of a modified triage criteria for a mass penetrating trauma like this. Maybe there is something different that would be beneficial. So I don't have a specific recommendation for how to do this, but this was something that our group thought was something to consider in the future. We talked about family reunification already. There was a further recommendation to have it near the incident site because so many people were showing up at the incident site. Maybe that's possible, maybe that's not, depending on the location of, you know, community facilities and things in the area. Staffing plans, this is the middle dot, should include all categories of staff. So everybody thinks about getting the doctors and nurses in, which is, I would argue, the most important thing. But what about the hospital administrators and the housekeepers and sort of everybody else that's going to be involved in the patients? The hospital administrators, some people would say, let's keep those people out. But on the other hand, the old PACU that's now being used as a SIM center but still has capable beds, somebody's got to make the decision to say, we're going to open that space up and we're going to be able to staff it and we're going to bring in the people. And so you have to have everybody on the recall plan to be able to come in and make those decisions. We had several of the participants that were involved in military civilian healthcare arrangements, and so the proximity of military resources, the collaboration with military health professionals that was found to be valuable in those organizations. And so a thought of how might we be better prepared for these mass incidents to have those collaborations kick into effect and increase capacity, whether it's capacity of healthcare providers or capacity of beds or different things. Is there a way that we might look at doing that in the future? Back to triage again, so sort of a repeated theme here. So this recommendation was specifically that a surgeon participate in emergency department operative triage, which I think is a unique way to think about this and probably quite important. So I think we're going to be really great at identifying in the department who's really sick, who needs surgery for the most part, right? But maybe, again, we have those 6 or 10 patients that need to go. It's a little hard we're not going to have the visibility of what's happening in the ORs upstairs, what surgeons are available, which case really should go before the other, who might be best off having a bit of additional imaging, et cetera. So having the surgeon there available to participate in making those operative triage decisions is important. And then the final bullet I wanted to point out on here is the last one, which says improved education and current treatment protocols for hemorrhage control and blood transfusion. And this was for medics in particular. So can we get our medics to be better at stopping bleeding and then replacing blood as needed? And so I really like this bullet because I just went through 19 recommendations with you for this study, eight high priority ones and then 11 that were in our second tier. And I would argue this is the one bullet that deals with a clinical situation, like truly clinical medicine. There's triage and things that are clinical related, right? But this is the one that says something about the way we actually do the medical care. And so out of 19 recommendations, there's one that was concerned with how we do the medical care, and all the rest of them are the other stuff, right? The systems, the way we communicate with each other, how do we screen patients. And so these participants who responded to these 6 large shootings felt like all the key recommendations or lessons learned are around those things. So the intubation will be fine. We'll get the chest tube in, right? But if we don't have the system designed where patients can be directed to the right place, and they're triaged appropriately, and we have all the right folks there, and we have the families out of the way, so we're able to take care of the patient, et cetera. And we can get our workforce back on its feet by having good mental health response. We can't do effective healthcare if we don't do those things. So this is really, ultimately comes down to a lot of system preparation, a lot of thinking for how to make that better for our next mass shootings. Okay, and with that, I'm going to turn it over to Paul to finish us out here.
Bring the microphone down to my level. Thank you so much. Obviously, Craig's data is absolutely incredible, and if you haven't had the chance to read his paper primarily, I would really strongly encourage you to. There's so much in there. Craig already referred to this, but the world is different, not just because of the frequency and scale of the mass shootings that we're seeing, but also the environment we practice medicine in changing, mostly for the worse, kind of across the whole country in terms of ED crowding. Just last year was the 10-year anniversary of the Boston Marathon bombings, and we in Boston were reflecting on what was different between 2013 and 2023. And I can tell you with certainty, and I've said this publicly in the media, we would be so much worse in Boston responding to the marathon bombing now than we were 10 years ago, because all of those surge actions, all of those things we did to make resuscitation capacity available in our emergency departments that allowed us to save lives, we are so much more constrained, we are so much more crowded, we really struggle to make even just head walls available to resuscitate a trauma patient, that I don't think we can do what we did 10 years ago. So we're going to talk about that. So, again, this is an audience that does not need any explanation about why ED crowding or the fact that ED crowding is continuing to worsen, but it is. There are so many initiatives trying to address boarding, trying to address crowding, but in most urban, suburban emergency departments, crowding is really, really bad. Many of us, probably most all of us, have had the experience of trying to just make one space available for an incoming cardiac arrest victim. But imagine 10 or 20 or 30. And I'll also say that we continue to cling to false beliefs about how much time we have. We say, okay, look, something terrible happens. Yes, Craig already said that the event happens at once, but maybe it'll take 20, 30 minutes for EMS to get enough ambulances, to do triage, to do some stabilization, to bring them into us. Again, in Las Vegas, 25 critical victims went to the closest hospital, which was the level 3 trauma center, in the first 15 minutes. So imagine any of your emergency departments getting 25 critical victims in 15 minutes. And obviously there are a million challenges with getting enough physicians, enough nurses, enough blood, all those things. But most of us probably can't imagine even just making enough rooms available to start the resuscitations. So what are we talking about? Well, resuscitation of critically injured victims requires space. You just can't do this in a hallway. Right, you can't intubate somebody, you can't put in a chest tube in the hallway, at least not nearly as safely or effectively as you normally do in regular care. And you've heard the framework that most of us in the disaster medicine world use, which is staff, stuff, space, and systems. And I think that really is important. We need to be mobilizing enough physicians, emergency physicians, surgeons, others, nurses, of course, head walls I will continue to talk about a bit more, blood products, lots of other things. But space is actually more than just space. Space is actually space plus staff and maybe stuff. And what I'm going to try and do is explain this to you in the concept of what we now call buffer zones. So my emergency department, probably almost all of your emergency departments, is just full with patients in the hallways. In my emergency department, I actually have a 17-bed acute unit and a 65-bed ED where the sick patients go. I have 11 additional spaces in the hallway that have central telemetry. We have 11 monitored hallway spaces because our 17 spaces are always full. And those monitored spaces are always full. So in an MCI, if God forbid something like Las Vegas happens in Boston, happens near my hospital, somehow I've still got to get those people that are in those bed spaces out into some other space so that I can do the incoming resuscitation of victims. The only way that works is, of course, I have to move them, but I can't possibly move them if there's not some other clinical team to assume their care, right? These are the sickest patients I have in the emergency department. I can't just throw them into some other back hallway that's even farther away than the hallway space that we currently use, unless there's a clinical team and some resources to be able to care for them. So we have been using at both Brigham and Women's Hospital and at Mass General Hospital within my system, our 2 level 1 trauma centers, we've been using this concept of a buffer zone. And again, we already use all our hallway spaces in the clinical areas, just like probably you do. So these are the next hallway spaces. This is that back hallway on the way to radiology that even we don't normally use as patient care space. But we have designated those as very specifically care spaces, and that is a temporary holding area where we can move patients to. This has to go as fast as a cardiac arrest in the inpatient unit. This has to be like any other emergency situation. And what we do is we actually have our hospitalists, our internists, on our mass casualty protocol, and they respond to it like they respond to a code on the floor. They run down, they show up in this buffer zone space, and they are now ready to take care of these patients that we are quickly wheeling out of the resuscitation spaces in the emergency department. So that very quickly, that patient with chest pain that's being admitted for troponin elevation can show up, can be put on a portable monitor, and has a doctor and nurse standing next to the patient to be able to assume care to do what they need to do. We wheel code carts back there. We wheel back a couple of oxygen tank suction canisters so that it becomes temporarily a surge space. And many of you may say, well, gosh, why don't I just send the patient all the way upstairs? It is not possible. There's no way I can send 10 to 15 patients upstairs into the hospital, identify spaces in that 15-minute window after we've heard that there's a mass casualty response. So ideally, your ED borders, some of you may be lucky enough to have your inpatient teams be covering those borders. That's the first group, right? Send those borders away, especially if they're covered. You've already made the decision to admit. They already have some sort of care plan. move those for sure. But that may or may not be enough. You may have to have some other patients who are halfway through their workup, but don't immediately need to stay kind of in your acute resuscitation area. And then sometimes other stable patients can go. But again, staffing, I think, is key to space. You can't create space if you don't have the staff for it. So we very clearly focus our physicians and nurses in the emergency departments, our emergency physicians, our emergency nurses, our arriving surgeons. We focus them on resuscitation of incoming victims. And then, as I said, we have hospitalists and then sometimes others. We mobilize some of our anesthesia staff if we don't need them in the operating room. They assume care of our patients that have been moved into these buffer zone spaces while our admitting office and our nursing supervisors try and find spaces upstairs. These are temporary. We try and make them as temporary as we can, but it buys us 30, 60 minutes of resuscitation time so that we can care for the patients. Again, it only works if people understand how critical this is. This is not like a normal handoff of a patient from the emergency department. This is like a code, and they've got to respond just as fast. We have support staff that have very specific checklists of, again, how many code carts to bring back to that hallway, where do they go, how many portable suction machines, how many oxygen tanks, et cetera. And then, of course, we have to have the back-end process of our admitting office and our nursing supervisors finding beds for those patients inside. So just to show you a couple of examples, these are tiny little architectural drawings. You don't need to look at them too closely. But the red square, this is the Mass General Emergency Department. Red square is that 17-bed area that I talked to you about. The yellow are our sort of intermediate care areas. They have central telemetry as well. But that purple area, those are really just hallways that people normally pass through on the way to radiology or on the way to going upstairs. Those are the ones we use, and they're just wide enough you can put a stretcher on the side and wheel another stretcher next to it, and we've got about 15 to 17 buffer zone spaces there. Brigham Women's, as I said, the other trauma center within the system that I work with. Again, same sort of color coding, the red zone, you can see the yellow and the green, but the purple areas, once again, are buffer zones. And it's really important to map it out ahead of time. So much has to happen so fast in an MCI that this is protocolized. There's no judgment, there's no figuring it out, there's no allowing the physician on duty or your triage nurse or your resource nurse or charge nurse to figure it out. These things are all pre-planned so that the arriving inpatient teams know exactly where they go, the equipment to save lives shows up right there, right when needed, and everybody kind of does what they're supposed to do. I think this is a fundamental part of how we respond to mass casualties more effectively in the world that we're in. None of us likes it. I really hate the idea that I'm even having to plan for this at all, because this is not really how an emergency department, I think, should work or how we should have to make choices. But if we don't do this, the alternative is we just don't have space to care for patients. And this has happened in some of the mass casualty events that we've been talking about. They just don't have the space, and that's one of many factors, I think, that can result in poor outcomes. So first off, I would really encourage you to plan for the realism of how MCIs happen. Again, as I said, I think in the last 20, 25 plus years, we have a lot of examples in disaster medicine of planning for myths and planning for misassumptions about what disaster events look like. There's a growing body of literature. Craig's study is one of the best that is out there that gives you the data on how these things work. If you're not a trauma center and you don't think you need this, you're wrong. 80% of people in an MCI go to the closest hospital. This is almost an inviolable rule with a few rare exceptions. Boston Marathon bombing was just partially because the event itself happened to be in the middle of all of our trauma centers just geographically. Again, Boston has more trauma centers than most cities, and of course we had a large EMS presence established. So I'd love to take credit for all the great outcomes that we had. I think we deserve a little credit, but I think some of the characteristics of the event really guided what happened. In most other events, the majority of patients go to the closest hospital and they don't care whether you're a trauma center. They usually don't know whether you're a trauma center. 80% of people, up to 80% of people, will come by means other than EMS. So you don't even get to tell the ambulances where to go. Uber, Lyft, pickup trucks, people running, they will show there. So every hospital has to have this, whether they're a big level 1 trauma center or not. It's not to say that you can turn a community hospital into one that can do 25 trauma resuscitations simultaneously, but we have to be able to do the most we possibly can, most effectively with the resources we have. So the buffer zone is a temporary space that allows you to create those resuscitation spaces. If you're not a trauma center, Craig was mentioning already some of the other things I think we really need to do. I think one of the most important additional things I would add into the list if I ever had the chance to write with a red marker is come up with community patient redistribution plans. Patients do go to the closest hospital. They tend to go to a couple of other hospitals. And if those 3-4 hospitals that have critical trauma victims are all calling the neighborhood level 1 trauma center at the same time and they're trying to redistribute their victims, most cities lack a really good plan to prioritize and figure out how we're going to get the most critically injured to the right OR, to the right receiving destination as quickly as possible. We need better community plans so that if you're a community hospital, your buffer zone allows you to create those resuscitation spaces, but rather than try and admit everyone, just use that as a staging area to transfer to definitive care. EDs have to be able to focus on arriving patients. That's what we do as emergency physicians as we resuscitate. We need to make sure that we aren't trying to run to the back hallway and care for those unstable cardiac, respiratory, other patients at the same time. And lastly, this is a whole hospital thing. Most of us in disaster medicine spend our careers trying to convince the rest of the hospital, the rest of the healthcare system that emergency preparedness is not just an ED thing. The emergency department is critical, but we are only one part of it. And I think effective MCI response is a whole hospital response. It's obviously your surgeons, your ICUs, your anesthesiologists, lots of nurses. But I would argue it's also your hospitalists and your internists. And we need to bring everybody together in one really comprehensive plan that gets exercised to work well. So I'll turn it back to Sam to see if we have questions. But events sadly are increasing both in terms of frequency and severity. We know that following the evidence base, as Dr. Goolsby showed, is really, really important. These recommendations, I think, are important for all of us to follow, not just in our hospitals, but in our communities. And I think we should exert leadership to try and work with our communities on this. And we have to have plans that reflect the reality of the world we practice in. If we ignore the reality, then our patients will suffer. So.
Thank you both. We have probably about 4 minutes for questions. Anything from the audience? Okay.
Was there any thought about trying to lift some of the scripts and send in some of the surgeons or stuff out to those community hospitals to help with the triage from those areas? Or help with the care? Like, is there a plan in place where in mass casualty that happens, there's a bypass plan, we send a surgeon to the other community hospital to help with triage, guiding care, possibly doing some operative management at that site?
Yeah, it's a good question, and I think the short answer is no. We didn't really come up with our participants in the mass shooting study in particular, and I think there's a few ways to think about it. So one that may be good because it could sort of decompress and you have some additional space, and then the problems with it could be if it's not sort of trained and exercised, you don't have your stuff, you don't have your normal team there that you're operating with, and so probably there could be a lot of downside to that as well. But it it could be part of a community or regional sort of plan to look at that. It just wasn't something that we talked about in particular.
Yeah, I would agree with that. That's pretty consistently the feedback we get as well. Is you can run out of surgeons pretty quickly, and then what's the utility of where they go best? Putting them in a community hospital OR, they're typically not very effective because they don't, as Craig said, know where things are. One thing we've been working on, and we don't have time to go in now, but I'd be happy to follow up with anybody through an ASPR-funded project called the Regional Disaster Health Response System, RDHRS, is actually a central triage portal where basically in the Massachusetts area, we're doing this in all of New England. If there were a mass casualty event, we establish one place for people to call with all of their trauma transfers. And what we do is man it with trauma surgeons, nurses, emergency physicians. They quickly get the vignette, penetrating gunshot to the chest, pressure of 80, da-da-da. And we can see all of that simultaneously. We talk to the trauma centers and get their real-time ED bed availability to receive resuscitations. And then we make the allocation decisions. It's physician-led, often trauma surgeon-led if we can, and helps us better use the resources we have. As I say, the Boston Marathon bombing, we were just lucky, I hate saying it that way, but the way the event played out. If the event were farther away from Boston, I think we'd have a real problem with all the hospitals trying to call different trauma centers, hey, can you take my patient? Hey, can you take my patient? Very poor use of resources, and I think terrible situational awareness.
So thank you.
Please.
Thank you guys both for this talk. This is awesome. We're doing a ton of work on all of this from a systems point of view. We're really starting to get into it. Did you guys look at all as far as simplification of
Yeah, so the question for those in the back was just about, was there a look at simplification of EMS protocols? So I think that, again, the recommendations that came out of our study in particular were fairly general. They weren't really like tailored to say like, here's a protocol, we're going to look at kind of X, Y, Z, what we may change. But I would say we spent a lot of time talking about triage. And so I think since that came up kind of over and over and over again as a theme, I do think there was a lot of feeling that, like, as we're looking about what happens on scene and how we're going to be able to identify the right folks in this type of a mass shooting, and to be able to move them appropriately, that does probably need some adjustment. And so I would imagine that hopefully would involve simplification rather than making it more complex, but that to have maybe a different lens or a different way that we would look at this type of a mass casualty.
And the only thing I would add, because we did a lot of discussion of this, both with the Boston Marathon bombing response, but then there was a whole CDC initiative years ago, A Tale of Our Cities, that was looking at other kinds of mass casualty events. I think one of the most important variables is how quickly you have EMS transport resources. Because if you think you have enough ambulances to be able to get your critical victims off scene, I actually think triage is really simple. I agree. I actually particularly, it's a pet peeve of mine that START has no allowance for penetrating thoracic trauma, which I think matters. But I think if you have enough ambulances, I think well-trained paramedics, EMS in general, can figure out sick, not sick. And you should get your sick patients, your critical patients, to receiving destinations as quickly as you can. As soon as you think you have more critical victims than you have transport resources, then the triage actually starts to change. How important it is changes, and what you do with the victims. But there were some folks, I will say, after the Boston Marathon bombing, that said, gosh, you didn't set up a red tarp and put all your critical victims on a red tarp before you distributed them out to the trauma centers. And I think that would have killed people. I think the fact that we cleared the scene of all critical victims within 18 minutes. Was exactly the right thing. It's part of why we do a lot of scoop and run, I hate to say, as an old EMS guy, in triage in general for trauma.
And I think to add, depending on where your MCI is and where the event is, the variability in protocols by city, by county, by state, depending where it is and what lines you're crossing, is another obstacle to overcome with that. Let's make this the last question.
Just like you're leveraging your internist and hospitalist and everyone else to take care of those patients in that buffer zone, leveraging EMS, we changed and have an operational protocol in Las Vegas after the shooting. Now we automatically, after a level 3 MCI or above, we automatically deploy EMS assets on a separate area of command. It's called the hospital area of command, directly to the hospitals closest to the shooting. Doesn't matter if you're trauma center or non-trauma center. And they do what they do best. You have company officers with scale within the incident command structure to bring as many fire assets as necessary or de-escalate as necessary. There's not a lot of those patients arriving by private auto, but what they do is let the emergency physicians, trauma surgeons, nurses stay in the ED, and they are able to do the triage, emergency treatment, and most importantly, when we drill this, moving people, like just patient movement in mass when they arrive in 10 or 12 at a time. That's a big deal. There's not enough grenades, there's never enough wheelchairs, never enough person power to move these people. And so I would just say also thinking about a community response, it's called hospital area command. So happy to.
No, I can't tell you how strongly I support that. I think that's a brilliant plan. I think all of us should have these automatically deployed patient redistribution systems for MCIs. I think that's great.
All right, thank you, everyone. Before you run out, I'll put a shameless plug. The Disaster Medicine Group has a sponsored session at 10 a.m. for 20 minutes, a short didactic downstairs in Levine B focused on how to mitigate labor action, particularly focused on resident strikes that have become quite popular in the last year or two. So just 20 minutes from 10 to 10:20 in Levine B if you're interested.